All right, so the topic of today's presentation is interventional approaches for cancer-related abdominal and pelvic pain. And I will focus particularly on three main procedures that we do for cancer-related abdominal and pelvic pain, and those are celiac plexus block, superior hypogastric block, and ganglion impar block. I don't have any conflicts of interest, and I will try to review the regional anatomy of visceral nociceptive signaling so that we can determine whether the patient selection criteria for the block and neurolytic procedure, and then we'll take some time to discuss evidence behind these procedures and complications that you might encounter. I will start off by introducing a case that I had a pleasure to be involved in several months ago. Our service was consulted for a 61-year-old male who was admitted with intractable pelvic pain likely related to invasive anal carcinoma. When we first saw the patient, the pain was around 8 out of 10 on numeric rating scale, and the pain was described as a pressure-like dull sensation, kind of generalized in the pelvic area. The pain was non-radiating, and we could not elicit any gross sensory or motor deficits on our physical exam. After several days, we actually managed to stabilize the patient on around 260 milligrams of morphine, but unfortunately, pain still remained quite poorly controlled, around 4 to 6 out of 10 on numeric rating scale. And by no stretch of imagination, this case is unique in any way. We all know that pain is one of the most frequent complaints in cancer, metastatic cancer or terminal cancer. And to make this even more relevant to our presentation, up to 80% of patients with gastrointestinal malignancies will actually experience moderate to severe pain at some point in their disease course. And if you ask your patients, most of them will tell you that pain is the most feared symptom of the advanced cancer. So what kind of pain are we really talking about? Well, the pain comes in 3 different flavors, if you may. You have visceral pain, somatic pain, and neuropathic pain. Now, in the real world, you never get a purely visceral pain or purely neuropathic pain, for example, but rather, the pain complaint is usually a constellation of these categories, but more frequently than not, one type of pain will predominate the picture. And knowing the distinction between these categories is particularly important because the blocks that I'm discussing today are mostly effective. The research has shown that they are most effective for predominantly visceral pain. So, how would a patient describe a visceral pain to you? Well, you need to understand that visceral pain largely originates from mechanosensitive fibers inside the abdominal and pelvic organs. And these fibers have very large receptive fields. So in other words, if you excite one visceral nociceptor, it will kind of activate several layers in the spinal cord on both sides and on multiple levels. And this poor anatomic differentiation actually directly translates into the description that the patient is giving you. So visceral pain is usually described as a diffuse in character, a poorly localized pain that is typically refers to another anatomic region and quite frequently is associated with emotional and autonomic response. If you look at the anatomy more closely, you will see that most of the visceral nociceptive fibers from abdominal organs kind of collect in one spot at celiac plexus, and then they divide again to synapse in the spinal cord. And this really invites a possibility to block most of those nociceptors as just one place, and that is exactly what celiac plexus is trying to achieve. So in other words, celiac plexus neurolysis will successfully interfere with visceral nociceptive signals coming from stomach, small intestine, liver, spleen, pancreas, kidneys, and GI tract up to descending colon. So who can help you do the procedure? Who can you refer your patients to? Well, pain medicine can do the procedure. Interventional radiology can do the neurolytic procedure for you, and actually gastroenterology can also do the procedure by endoscopic ultrasound guidance now. By no means these techniques that these specialties use are created equal. In fact, there are some differences, but I think that's kind of beyond beyond today's presentation. But if anyone has if anyone has questions regarding the techniques and the differences between these three, I would love to kind of come back and discuss them. It turns out that celiac plexus neurolysis is actually quite effective. Several prospective studies have shown that celiac plexus neurolysis can actually achieve a better pain control when compared to maximal medical therapy alone. Celiac plexus neurolysis can dramatically reduce the opioid consumption, and if the block is introduced early on into the disease course, the incidence of moderate to severe pain will actually go down 3 and 6 months down the line. Several studies, but not all of them, showed improvement in functional capacity as assessed by Karnofsky scale and an improved overall quality of life. One study actually even showed a survival advantage. And if you really think about this, it's not that surprising. You know, if you shave off that 600 milligrams of daily morphine from all of your patients, no wonder their quality of life and functional capacity can improve. Unfortunately, as everything in medicine that we do, this block also comes at a price. Most of the complications that we see are transient. Most frequently, you will encounter with transient orthostatic hypotension, transient diarrhea, and transient low back pain. There have been reports of catastrophic complications like sustained diarrhea that resulted in death, or a paraplegia right after the celiac plexus block, but those complications are extremely, extremely rare. Now, moving down further the line, pelvic area, just like the abdominal area, will relay most of its visceral nociceptive signaling through one plexus, and that plexus is called superior hypogastric plexus. So in other words, most of the visceral nociceptors from distal colon, bladder, and male and female sex organs will travel through hypogastric plexus. And again, this invites an opportunity to get most of those nociceptors at one place, just in front of the L5 vertebral body. Again, the block has been shown to be quite effective. In fact, the studies that I referenced on this slide showed that 2/3 of the patients experienced about 70% reduction in pain, and those 2/3 of patients also reduced their opioid consumption by about 70%. In fact, the remaining 1/3 of the patients, the so-called failure group, also reduced the opioid use by about half. And failure in these two studies was defined as a failure to achieve pain relief that was 50% or more. Unfortunately, pain medicine is the only specialty that can do this block for you, so your friends at interventional radiology might not be that helpful. The block is quite frequently done for non-cancer related pelvic pain as well, but again, I think that's kind of beyond this presentation today. Again, complications are fairly transient. Quite frequently, you will see a transient diarrhea, a transient low back pain, and a transient orthostatic hypotension. I was actually specifically looking for any neurologic complications, and I couldn't find any of that report in the studies published up to date. And I was looking for this because if you look at the technique, the way this block is done, one would probably not be surprised if they saw L5 nerve root destruction by an improper placement of the needle or something like that. But studies that we have until now, they have not described such complication to happen. And lastly, ganglion Impar block that is relaying most of the nociceptive information from the perineal region, distal part of the urethra, distal third of the vagina, vulva, rectum, and anus. Again, studies published so far that assessed cancer-related perineal pain were overly positive. Most of them showed more than 50% reduction in pain, but unfortunately, all of those studies were underpowered. We don't have any systematic review. We don't have a meta-analysis to date. And the studies that are published up until now, they are on 20 patients or less. So fairly underpowered studies. Now, I've been using block and neurolysis quite interchangeably, and in fact, they are not interchangeable at all. In fact, when we say block, we really mean the use of a local anesthetic that will transiently block the impulse transmission. On the other hand, by neurolysis, we mean, in these cases, a chemical destruction of the nerve tissue, usually done by absolute alcohol, sometimes by a concentrated phenol. And knowing this is quite important for hospice and palliative care doctor, because in today's pain medicine, most of the procedures that we do, we usually do diagnostic block first and then plan for the neurolytic procedure. And that is kind of the standard of practice in pain medicine. But I think the procedures that I'm discussing today are an exception to the rule. In fact, there's no study that has shown that block is diagnostic in any way or has any kind of predictive value. In fact, doing block first and then planning for neurolytic procedure might actually delay the much needed analgesia provided the neurolysis, and then you might be subjecting your patients to a twofold increase in side effects. So this might be a helpful information to have at hand when discussing your patient with the interventionalist. And I would strongly argue that going for the neurolysis without the diagnostic block is the best approach. And lastly, when I was collecting the data for this presentation, I really wanted to answer one important question. When should we be referring our patients for these blocks? In the House of Medicine today, interventional procedures are regarded as kind of a last resort options. And I was wondering if the data supports that. In all the studies I looked at, and quite frankly, all the studies that have been published so far support early procedure rather than the late procedure. In fact, when you do the procedure early on, chances of getting a successful block is much higher. That is because the anatomy around the plexus might be less altered by the neoplastic process, and studies have shown that the spread of the anesthetic, spread of the neurolytic substance will directly affect the outcome. Introducing these procedures early on will also likely decrease the opioid consumption for your patients. The early procedure will likely improve functional capacity in your patients, and most importantly, it will most likely decrease the incidence of moderate to severe pain 3 and 6 months down the line. And then these neurolytic procedures are actually regarded as quite safe procedures. Most of the side effects that we see are transient, and I think the most recent Cochrane review really put a nail on the head when they wrote that celiac plexus neurolysis causes fewer adverse effects than opioids. So if you wanted to place these interventional procedures on a WHO analgesic ladder, I would strongly argue that they belong on a step 2 of that ladder. And I wouldn't be surprised at all if a lot of physicians place them on step 1. And this is such an important slide. I think if there's just one thing that you want to take from this presentation, this slide might be it. Circling back to the case, just to remind everyone, we saw a 61-year-old male patient who was admitted for intractable pelvic pain, likely coming from locally invasive anal carcinoma. The pain was predominantly visceral in character. And we were able to get the pain down to around 4 to 6 with about 260 milligrams of morphine. Now, something that is also quite important, something that was also quite important in this case was that the patient was homeless and had an active substance abuse. So from the pain management perspective, this patient was in a high-risk group for opioid-related aberrant behavior. And to kind of put that in perspective, more than 90% of patients in a high-risk group will demonstrate opioid-related aberrant behavior. And although I absolutely agree that treating pain is of utmost importance, I think we should never downplay the suffering that opioid misuse can cause to the patient, to their families, and to the society. And I was wondering if anyone wants to volunteer and share their kind of plan of attack. What would you do in this case?
Any thoughts out there from the group about this case? Please feel free to unmute yourselves with the microphone icon on the Zoom toolbar, *6.
Well, this is Sarah. The first thing that comes to mind if I'm listening to all this is what are patients' wishes? Certainly at this time is what are his wishes for care to manage the pain? What are the options? So that's certainly something that I would have had a conversation somewhere there along the way, or to know, what do you want to do? What are you willing to do? What does he want to do? Because certainly all these barriers, that many don't want to do anything about it, don't have, the inkling to want to change any of those social barriers that come across.
I agree. I think that is a very important point. And in this particular case, patient kind of gave us the full freedom to treat his pain maximally aggressively. He was okay with interventional procedures. He was okay just continuing the medical therapy. So we did not have any constraints in that regard.
It's the social barriers that obviously impact and has that vicious circle of ending back in the emergency department.
Sure, and we really wanted to reduce the opioid consumption as much as possible. That was one of the goals for our team, actually.
Rick, do you have something?
Yeah, I was going to say, the first thing that comes to mind are, the two top challenges, and that's the substance abuse and the homelessness. Obviously, he doesn't have money or resources, and I was just thinking, plug him into whatever, social services support might be available, because that'll make a difference in the consistency of his follow-up and compliance and things like that.
I agree. So would you continue the opioid therapy and kind of try to titrate it up, or perhaps rotate him to another full mu agonist?
I think, we still do all the normal things, get an opioid contract, trying to create incentive for him to realize, you know, he's being cared for, his pain's being addressed, but, you know, try and shift some of that ownership onto him, even if it's just in the form of follow-up, maybe
Sure.
limiting how much medication. Like I would limit how much medication I give him almost as a way to try and induce compliance, right? Get him to come back, but have that conversation that lets him know that, you know, hey, I'm here to help.
Sure.
This is my part. This is your part. You know, and again, I think the big piece is trying to get him plugged into some social services so that he's both motivated and has the resources and, you know, just, I guess same concern, right? He's going to fall back into the system. He's going to fall back into homelessness. He's going to use the emergency room as his primary care and or source of medications in lieu of appropriate treatment.
Right. So what we actually did for this case is we referred the patient for superior hypogastric plexus neurolysis. Just to kind of remind everyone, superior hypogastric plexus will relay most of the nociceptive innervation from pelvic organs, and we believe that most of the pain was in the pelvic area, and we also believe that most of the pain was visceral in character. And actually the neurolytic procedure proved to be quite a success. Pain was reduced on average to 0 to 2 out of 10 on NRS, and patients successfully reduced the opioid consumption to 30 to 60 milligrams of morphine, and the effects remained there, and we had a sustained effect for several months until patient unfortunately passed on. To kind of summarize today's presentation, celiac plexus block, superior hypogastric plexus block, and ganglion impar block are mostly successful and effective for visceral pain. For abdominal organs, you might want to think about celiac plexus neurolysis. For pelvic pain, superior hypogastric neurolysis might be a better way to treat the pain. And lastly, perineal pain is best treated with ganglion impar. There are papers that actually combined celiac plexus with superior hypogastric and superior hypogastric with ganglion impar with a very good result. So if you want to go that route, that is also a possibility. Neurolysis without diagnostic block is probably the best way to go, and I strongly believe that an early referral is better than a late referral. I thank you for taking time today, and I would gladly answer any questions that you might have.
Dr. Isabu, with, I apologize if I didn't pronounce your name correctly, but
That's okay.
With the neurolysis, what are the potential complications, and what's the follow-up to make, you know, to kind of make sure that those complications aren't taking place? And then in someone like this who's a homeless person and may have more of a challenge to follow up, do you worry about that a little bit more?
So yeah, that is a very good question. Most of the complications that we see with these procedures, all three of them, they are usually transient. The big three that I highlighted here are transient orthostatic hypotension, transient diarrhea, and transient low back pain. We actually treat the first two in the clinic before doing the procedure by loading the patient with some fluids. Then patient usually goes to the recovery area, stays there for several hours or even a day, and then most of the side effects are managed over the phone and by a follow-up. There have been reports of catastrophic complications, developing paraplegia. Actually, we tend to believe that is because that is due to the reaction of spinal arteries to the absolute alcohol. They transiently spasm and cause a spinal cord ischemia, but again, that has been very rare, very rarely described, but but still they're out there and they can definitely happen. Another important thing to consider perhaps with celiac plexus neurolysis is that depending on the approach you're going to take, the side effect profile might actually differ. For instance, trans-aortic approach, the study that I referenced here only saw orthostatic hypotension in 10% of the patients, while if the procedure was done as Planck neurolysis or a retrocrural approach, the incidence of orthostatic hypotension was almost 50%. So you might want to discuss that with the interventionalist when you're referring your patient to them. Did that answer your question?
Yes, thank you.
Dr. Escobar, kind of a similar question here from two participants. So who does these procedures in Nevada?
So for celiac plexus, as I said, let me go back to this slide. For celiac plexus, pain medicine can do the block and neurolytic procedure, both of them. Interventional radiology can do them, and very frequently GI will do the neurolytic procedure while they are in there to do a biopsy or some kind of other procedure. That's for celiac plexus. For superior hypogastric and for ganglion impar, unfortunately, you don't have much choice. You will have to refer your patients to a pain medicine doctor, because pain medicine is the only specialty that will help you with that for superior hypogastric and for ganglion impar. And actually, for this patient, we asked our interventional radiology, and they told us that they couldn't do the procedure for us, so we had to refer the patient to the community to do the block. Actually, the pain physician came to the hospital and did the block for us.
So they're fairly widely available procedures.
Yes, they are.
Okay. So the side effects you mentioned, the diarrhea and others, are those relatively minor in most people?
So as I said, they are usually transient. They usually last up to 1 to 3 days, and then they kind of disappear. But rarely, especially diarrhea, has been sustained and resulted in some serious life-threatening complications. But usually, yes, they are transient.
Dr. Conrad, do you have a question?
Yes, actually not a question as much as a comment. I think, as a palliative medicine physician, if I were considering referring a patient out for these procedures, it is important. You might have to call an office or check with somebody, because there are pain medicine specialists. There are different routes for somebody to be a pain medicine specialist, and there are some out there that are non-interventional pain specialists. So you would need to do your homework and make sure that you're referring to someone that actually practices interventional pain medicine. I can't tell you the percentage of practitioners out there that are non-interventional pain specialists, but just to sort of raise the awareness of the audience.
Yes, I think that is a good point, Dr. Conrad. Not all pain physicians will do these blocks, so you might need to kind of talk with them first before making the referral.
Orthostatic hypotension is a very common problem from my viewpoint, even from a hospital medicine viewpoint. And a lot of times it can be fixed with some fluid. Sometimes it's autonomic dysfunction due to diabetes. Is it with the procedure? Is it cumulative?
So the mechanism behind orthostatic hypotension, particularly with celiac plexus block, is the destruction of sympathetic innervation. These fibers, the nociceptors, are closely associated with sympathetic fibers, and actually large portion of celiac plexus carries out a sympathetic innervation to the abdominal organs. And by destroying that, you're essentially causing a massive vasodilation. And that is the result. And the result of that is orthostatic hypotension. So, in other words, yes, it can definitely be cumulative. And it can definitely increase all the risks that are associated with orthostatic hypotension, like risk of fall and so on and so forth.
Question here from Zeri. What is the incident of death for these procedures? Should that work into consideration in a hospice patient? I'd imagine comfort is the most important goal.
Sure, a very good question right there. As I said, the complication rate, like devastating complications from these blocks are quite rare. Unfortunately, I cannot give you a percentage. I'm sorry about that. But I will say that none of the prospective studies I looked at, and there are 4 prospective studies published so far, none of them had complications that resulted in death or severe comorbidity. As I said, there are just case reports and case series of such complications. And then, yes, I agree, comfort is usually the most important goal. And I think it's, but the only real contraindication with these blocks is the inability to obtain consent from the patient. In fact, you can do this block with a patient who has an active and ongoing infection. We've done that, and that has been done in the past. You can do these blocks in a patient who has poor platelet function, for example. So it's really a discussion that you need to have with your patient, where the benefits outweigh the risks.
Thank you. Great talk. Thank you.
Sure. Thank you.
Great questions, everybody. Any other questions or comments? Dr. Conroy?
Yeah, what I wanted to say is I really enjoyed getting to learn about this topic, and as Dr. Essebua prepared it and thought about the teaching points, the take-home point for me as a palliative physician is the early referral, because at my hand and with my training, all I know is to prescribe, and at times I've had patients with such severe cancer-related pain, you know, I've had to prescribe them basically to the point of what some might refer to as palliative sedation, because that's the only tool in my pocket. And so I think of the saying, you know, the eyes see what the mind knows. And so my practice will change in really considering much earlier referral for, you know, these situations that cause immense suffering. And I really love the point that Dr. Essebua made about the suffering that can come from the prescription of some really markedly high opioid doses. So I feel like I've got sort of a, you know, an enlightened viewpoint that is a new tool in my pocket now to help our patients who are suffering.
Thanks, Dr. Conroy. Any other comments or questions?
I have a off-label question for the palliative care panel if anyone wants to give some input on it.
Yeah, go ahead, Rick.
Does anyone have an overview? Have you seen any end-of-life patients with idiopathic pulmonary fibrosis? And if so, what does that end-of-care life plan look like? I should say end-of-life care plan. I kind of reversed it.
So this is Dr. Conright, and we see those patients pretty frequently in our practice. Just generically speaking, the first point of any standard palliative care is to have a nice goals of care conversation with them. And that goals of care conversation would include making, learning to know what they understand about their illness, and, and what the picture looks like in the long run, the disease trajectory. And if they don't have a complete understanding of what that looks like, ask permission to share what the disease trajectory looks like, and assist the symptom burden and the impact of their illness at that point in time. And of course, we would focus any symptomatic efforts to address the symptoms that they're having, whether it be cough or shortness of breath. Those would be two very common symptoms that we might see in somebody with idiopathic pulmonary fibrosis. Also, anticipating the future, knowing this is a terminal condition, we would explore with them their values and their goals of care, and anticipate potential complications, and in the context of their values and goals of care, come up with a plan of what sort of life-sustaining treatments they would want and on what basis. For example, hospitalization, ICU care, possibly even intubation and ventilation. Would they want to have any part in those life-sustaining treatments? And if they do, to what end? And we would work to align their plan of care in the future with what their values and goals are. So if somebody really wanted to avoid the hospital, depending on where they were in their disease process, we might possibly refer to hospice. If they were earlier in their disease trajectory and were willing to have some trials of life-sustaining treatments, we might help them create a pulse, that indicates that they would want trials of these life-sustaining therapies, but hopefully in collaboration with the patient, maybe put a limit on, like a trial of intubation with the goal of returning home to independence so that they can enjoy their remaining days with their spouse and their grandkids and pets, whatever matters to them. So goals of care, creating a life-sustaining treatment plan, hopefully in the form of a pulse if they're further advanced in their disease, with careful attention to symptom management that they're having. For example, we just, in the past week or so, we're working with an outpatient doctor whose patient had idiopathic pulmonary fibrosis, and they were really, really bothered with a cough. And so our care team gave the documentation and support for the doctor to give ongoing prescribed codeine, which really, really addressed this horrible quality of life altering cough that was problematic for the patient. But the doctor really wanted the backing of the palliative care team to say, yes, go for it, keep prescribing the codeine, this is appropriate. I just said a whole bunch of stuff. Did that help answer your question?
Was all very helpful. Thank you. I don't want to monopolize the conversation, but if no one else has any questions, can you, what does end of life normally look like for those patients? Is it palliative care? Do they end up with an ARDS type picture? What is it, kind of across the board?
I have seen a number of circumstances happen. We've had the good fortune. Now, I think I mentioned that I work for the VA, and the VA nationally has invested tremendous resources towards palliative and hospice benefits for veterans. And we've happened, fortunately, our system knows us. We get a lot of early referrals. And, the main issues that we've seen have to do with this dyspnea that can become quite disabling. And if they get to the point where they're disabled with dyspnea, if it is in their goals of care, at that point in time, that would be when we would refer them to hospice to keep them as comfortable as possible for whatever time they have left and out of the hospital setting.
That's helpful. Thank you.